If I could have your attention, it's my pleasure to introduce Dr. Aaron Vissman from the Talbert House. Aaron did his training for his MPH degree at San Diego State University, where he focused on health services administration. He then went on to get his PhD at Emory University, where he studied behavioral sciences and health education. After that, he went on to work at Wake Forest in North Carolina, where he focused mainly on HIV prevention efforts and community outreach, working with immigrant Latino populations. He is now currently the Associate Director at Talbert House, where he is heading their research efforts. I'd like everyone to welcome Dr. Vissman, and I hope you enjoy his presentation.
Hi. Thanks. So there's a little reverse of the sequence, not that important, but I worked at Wake Forest between my MPH degree and going back for my PhD. So that was in North Carolina, and we worked on a community-level HIV prevention intervention known as Hombres. Anyway, that's a CDC-supported effort at this point. So after going from North Carolina to Emory, I focused a bit on legal stress and legal status of immigrants for my dissertation work, and then came back up here to work at the Center for Research at Talbert House. So the research center has only been around for a couple of years, maybe 3 years at the most, whereas Talbert House, the service agency, has been around for at least 50 years or more. And Talbert House, the service agency, started as a halfway house provider, taking people who were in prison and needed to get out one way or another. They provided services to those folks, and that was sort of an innovative concept about 50 years ago. So they've expanded a lot since then, and they do outpatient clinical services for people with mental health issues. They do court and corrections services. They do several other things. And like I said, just in the past 2 or 3 years, we've developed this Center for Health and Human Services Research. And today I'm going to focus on just a couple of studies that we have going on there. Both of the studies involve opioid overdose prevention programs in Ohio correctional facilities. And then for the second part, I'll focus in a little bit more narrowly on what we're calling at this point the peer op or peer ops intervention. So I guess a note on the title. This is sort of a working title for this intervention. It stands for Post-Entry, Exit, and Recovery Opioid Overdose Prevention Programs. S is in brackets because at this point we're sort of assuming that a standardized prevention intervention might be useful across all of our correctional facilities, and then it may also be useful across correctional or community correctional facilities throughout the state. But differences that we may discover through the research process, and individual differences, group differences like gender, or facility level or policy level differences, those may suggest that we should develop several peer ops for different programs. Before I get back into the details of that, I figured I should provide a basic sort of introduction to opioid overdose epidemic. For those of you who may not be as familiar with that, I'm sure a lot of you are pretty familiar with it. I'll talk about naloxone as a sort of short-acting antidote for opioid overdose, and I'll talk about some other aspects of the history of drug development. I'll get into the first study that we have preliminary findings for on the prevalence of naloxone education and distribution in Ohio. Then I'll provide a bit more introduction on survival analyses and what they suggest for ex-prisoner research, gaps in that research, and then get back into kind of peer ops as we're developing it at this point. So it's pretty early in that development stage. I think, like I said, most of you know that there's been a doubling of opioid or drug overdose in general in the United States for the past 15 years. The death rate went up from 6.2 per 100,000 in 2000 to 14.7 in 2014. Unintentional drug overdose deaths surpassed motor vehicle deaths as the leading cause of injury-related deaths back in 2007. Around that time, 2007, 2003 to 2007, there was a bit more national focus on overdose as an epidemic. In 2007, Purdue Pharma, the manufacturer of OxyContin, actually settled on criminal charges and paid out something about upwards of $600 million in fines associated with misleading advertising and marketing practices. But as you can see in the bar graph, the absolute numbers of deaths continue to increase despite this sort of punishment at the corporate level. And today, you see about 50,000 absolute deaths in the United States. You see men and women separated out in these lines. But when we think about 50,000 deaths in the United States, it's comparable to HIV/AIDS at the height of that epidemic. And as I'm sure you know, that the rate increase for AIDS in the mid-'80s to 90s was a lot steeper. But the time frame is similar, about 15 years. And whereas HIV/AIDS in 96 was starting to plummet based on a really good HIV case definition that was rolled out in 1993, and antiretroviral drugs that were discovered and developed and rolled out in 95, 96, there was that sort of real plummeting in the death rates for AIDS. But we don't expect to see any sort of drop-off. There have been in overdose deaths or opioid overdose deaths, there haven't really been discoveries that are comparable in testing or treatment in that area. So we've seen really high spikes in opioid overdose deaths here in Ohio very recently, and there isn't a whole lot of evidence to suggest that those are going to drop off, at least not in the way that HIV/AIDS did. I figure I'll go through some points on this timeline. I got a pretty long timeline, and I'll focus on kind of the drug discoveries. So morphine is an alkaloid isolated from opium back in 1800. Codeine was also an alkaloid isolated from opium at that time, and those were started to be used in medicine for pain management. Jumped to 1916, oxycodone was first synthesized by the Germans, I believe, and 84, FDA approves Vicodin. It's a hydrocodone opioid. 85, FDA approves OxyContin. 1990, AMA first designates addiction medicine as a subspecialty where it hadn't been designated before. A lot of people hear about fentanyl and believe it's a relatively new drug, but that's been around and approved by the FDA since 1990. 97, pain is termed the fifth vital sign by the American Pain Society, and it's sort of indicating that it should be measured frequently along with the other four vital signs, which are blood pressure, heart rate, temperature, and there's a fourth one. But basically suggesting that pain should be considered on a regular basis and measured and treated. 2002, FDA approves Suboxone. Suboxone is called a partial agonist, meaning that it has some of the properties of methadone and some euphoric effects, but it has a combination of naloxone that blocks that in some way. 2010, FDA approves Vivitrol, which had been around for alcoholism, a treatment for that for some time, but they approved it for opioid-dependent patients as well. Vivitrol is called an antagonist, meaning it blocks it has a better affinity for the opioid receptor, so it sort of blocks activity there for a more extended period of time. 2011, American Society of Addiction Medicine adopts a new definition of addiction, but this new definition isn't used for clinical diagnosis. It's not like the DSM-4 or 5 where you can score somebody on one way or the other. So in that sense, it sort of aligns with NIMH and NIH research and concepts, but it continues to sort of create some separation between the research and practitioners who use DSM-5 and DSM-4 in our organization sometimes, despite the fact that NIMH withdrew support for that in some sense back in 2013. 2014, 2015, FDA approved naloxone in 2 different forms, injection and nasal spray. And those are the innovations that we're really studying, the dissemination of naloxone across our facilities and throughout the state. These forms of naloxone are really short-acting, and depending on what level of opioids you have in your system, you may take a few doses of that, and you may return to respiratory arrest afterward. So it's really a short-acting form of the drug used for emergency purposes. So I think that timeline, at least for me, you may have read some of the other points on the timeline. It provides a pretty coherent narrative about the epidemic and how it's sort of developed and increased. There's basically a major effort to develop new opioid drugs and market those throughout the United States. There was a sort of federal effort to get rid of pill mills and sort of places like that were distributing those medicines at some point. There was also efforts to reformulate OxyContin and other related drugs so that they're harder to abuse. And those sorts of efforts shifted people who were addicted to heroin and other sorts of more available drugs that were cheaper, and I'm sure most of you are pretty familiar with that narrative about how the epidemic developed, and associated HIV and HCV peaks related to the shift to injection drugs. But I wanted to go through the series of maps pretty quickly because I think it provides a sort of parallel narrative about how abuse spread and where it started. So back in '99, before anybody was talking about opioid overdoses as an epidemic, you can see that there's a couple of places and a cluster in Appalachia that already has death rates that are well above our national average today and really sort of off the charts on the spectrum. I know you can't see that, but the darkest red is 20 or more overdose deaths, age-adjusted per capita, and the bottom, the other end of the range is 0. So you can see in '99 it's pretty tranquil across the United States. However, there are 2 counties in West Virginia that are over 20 deaths per 100,000 at that time, and about 13 counties surrounding that that are over 16 per 100,000, which is above our national average today. I think it's Diariba or something like that in New Mexico, and Humboldt County, of course, in California, have high rates, and a couple other isolated counties, but that's about it in the West. Nowhere in the Northeast is comparable, obviously. Jump to 2003, you can see a pretty major expansion into Kentucky for those counties that are already kind of off the chart, and expansion in New Mexico. Jump to 2007 when the Purdue Pharma settlement came through, and overdose rates jumped to they jumped to a leading cause of death higher than car crashes. You can see the spread of counties in Appalachia, even further into Tennessee and into Ohio. But you can also see throughout the U.S. there's a lot more prevalence of counties that are at or above our national average today. 2011, there's a major expansion of sort of off-the-chart counties throughout different parts of the United States. Now there are some in the Northeast. And you can see the Appalachian cluster has gone well into Ohio, Virginia, further into Tennessee and other states. And now today, this is the most recent CDC map available with this sort of data, and you can see it's sort of a blanket of what used to be off-the-chart rates. What's hard to see in those sorts of maps are counties in West Virginia and just how far off the chart they've gone. Last year, West Virginia had 41.5 deaths per 100,000. Ohio and Kentucky tied for third place at about 30 per 100,000. And some Ohio-specific features, there have just been significant increases, sort of record-breaking increases for the state in the last couple of years, and an unusually high spike in fentanyl and carfentanil-related deaths, which causes a unique clinical feature of chest wall rigidity, which you can read about, sort of an anomaly that I can't explain the details of. But these fentanyl and carfentanil-related deaths were the target of investigation by the CDC. They sent out an EpiAid team of investigators, and they found some correlates associated with death from fentanyl versus other drugs, which you can talk about that if we have time. Around this time frame, 2014, Ohio passed some legislation, like a lot of other states, that allowed medical professionals to provide naloxone to friends, family, and really just about anybody who could provide assistance to somebody in an overdose emergency. Again, naloxone is this short-acting opioid antagonist acting on the mu-opioid receptors in the central nervous system. Another part of the legislation provided good faith immunity for folks who may call 911. It was designed to increase people's, they call it good Samaritan behavior in some places, where if you're to call 911 and the police come, especially if you have a previous conviction, you may be worried about an additional charge for drug possession or something like that. So these sub-provisions of the law or clauses allowed for good faith immunity. And as you can see, consequently, all of the staff in our facilities, at least the facilities that treat high-risk patients, people diagnosed with opioid use disorder, they could potentially have naloxone on site. And we received some state funding from the Ohio Office of Criminal Justice Services to study that phenomenon at the state level, not just in our facilities. We partnered with Erin Winstanley, who's actually faculty here and has recently moved from UC to West Virginia, the forefront of the epidemic, where she's in this, I think, this College of Pharmacy there. So the first study that I'm going to give you some really preliminary results from had 4 goals. I'll just talk about the first one, but it's basically to document prevalence of naloxone education and distribution programs and high opioid overdose death counties. We wanted to look at barriers, examine attitudes of program directors, and also examine attitudes of staff and willingness to administer naloxone. So when you think about, are these findings already out there? What surveys are already looking at this type of thing? There's one national survey, NSATS, that is doing this type of work. Every year they survey substance abuse treatment service providers, and some of the recent results indicate that despite this epidemic, there's been pretty small, about 5% increase in U.S. facilities. There's been a very small increase in facilities offering medication-assisted treatment, meaning buprenorphine, methadone, the other drugs that I talked about earlier. And in Ohio, in the last couple of years, there's really been no increase, according to their survey, in the number of facilities. The NSATS doesn't ask about naloxone. That's not part of their survey, at least it hasn't been in the past. And they actually exclude criminal justice treatment providers, which is what Talbert House operates for the most part. So there's a need for this type of independent survey. The Harm Reduction Coalition was the only other assessment out there that was looking at this, but their study was rather biased in the sense that it just surveys their list of affiliates. So agencies that are already affiliated with the Harm Reduction Coalition, they surveyed them and found that a really high level, 66.2% of their respondents had been distributing naloxone vials to lay people even before the new legislation came about. But as I said, that's a sort of unusual sample of people who are agencies that are affiliated with that coalition. So this is our sampling frame. We have the scare quotes there for high overdose death because we used Alexander Wally's definition of high overdose, which was very kind of a low bar, counties having greater than or equal to 5 overdose deaths per capita in a time frame. So obviously almost all of Ohio qualifies when you use that definition. And we use data from the Ohio Department of Health to create that sampling frame. We use two different registries. We use the Ohio Mental Health and Addiction Services Registry, which is what SAMHSA uses, so it's basically the same list that NSATS uses. And then we also use the DRC, Department of Rehabilitation and Corrections list, which is corrections providers. We had to exclude about 24% of that 850 for various reasons. Some of them are duplicates, and basically for corrections facilities, we're only including corrections facilities that were also substance abuse treatment facilities. So there's a number of facilities that were excluded for that criteria as well. There's two mechanisms for data collection. We had telephone interviews of CEOs and facility directors, similar to NSATs, and phone and email reminders. And we also used mailed surveys to staff. But I'm not going to talk about those results. Could come back another time and present that data. Questionnaire content, we basically used a lot of the items that Knudsen and colleagues used at the University of Kentucky. I can talk about some of the details of those assessments if we have time. In terms of just the prevalence measure or items, that's these four. We asked a sequence of questions and a structured interview. Does your program provide overdose prevention services? And then drill down on education and naloxone distribution. Does your overdose prevention program provide naloxone? And then we drilled down on kits versus prescriptions for naloxone. I think there was an open-ended component to that as well. We use a standard approach for analysis, looking at distributions, differences comparing t-tests and chi-square, and logistic regression. However, those results, again, we've collected a lot of the data. We're not really at the stage to present these statistical models. And our response rate was, as you'll see, pretty low, so it's going to reduce our ability to do HLM with at least the director level data. And here's our response rates. We got, at this point, only 22% of participants. This is a product of NSATs. Basically, if you participate in the NSATs, you get put on their list of registries. We don't really have any benefits to offer directors to participate, so that's maybe a limitation of our study sample. But even with 141 participants, it's, as you saw on the other slide, it's comparable to the harm reduction coalition sample, which was a national sample, but we have about the same number just for Ohio. And we had a pretty good cooperation rate. So when we're thinking about beyond outpatient clinics and residential clinics that offer this basic form of public health intervention, naloxone distribution, there's several different categories that aren't included in most research and aren't really included in a lot of public health prevention efforts. And those are halfway houses, community-based correctional facilities, jail-based facilities, and we also captured some other types of facilities, most of which will be recategorized into an above category. When we look at some of the measures that Knudsen and colleagues used, and we look at these distributions across facility type, you can see that the CBCFs, the community-based correctional facilities, had far and away the largest number of full-time employees. As you can see down a bit lower on the clients row, outpatient clinics, kind of common sense, support services for a lot more clients. But when you look over to the other part of the chart under halfway houses and CBCFs, we have a lot of clients that are sort of available on a daily basis for treatment, or at least possibility of exposure to prevention education. So sort of highlighting just here the differences in characteristics across facilities, and thus the differences in preparation for generalizable prevention intervention. When you look at the row for percent with opioid substance abuse disorder, it's pretty clear that 50% or more of all of these facilities report having, about 50% of clients in each of these facilities, according to directors, are diagnosed with substance abuse disorder. And we would assume that there's a lot of undiagnosed clients across the facilities as well. In terms of treatment approach, again, these are the categories of that were measured by Knudsen and colleagues. You can see that cognitive behavioral therapy was the most common treatment approach across outpatient clinics, halfway houses, and CBCFs. Inpatient or residential clinics reported a bit more of the 12-step model. These variables ultimately will be included in a predictive model for uptake of naloxone interventions. You can see program adoption. These are basic prevalence findings. You find a wide range of differences in uptake of prevention education programs and differences across facilities and how they deliver or whether they deliver kits or prescriptions for naloxone. So basically what we've found in the study so far without doing any multivariable modeling is that, as expected, there's a pretty wide variation in prevalence of overdose prevention education and distribution programs across these different facility types. And compared to the 66% in the Harm Reduction Coalition sample, we're looking at much, much lower. And also, when we think about all these facilities are putting themselves out there as treatment providers for folks who have substance abuse disorder, and opioid use disorder is common in going on half of these clients, it's really standard of care, or probably should be seen as standard of care to offer these naloxone education and prevention programs on site. And as you see here, there's a pretty low rate that we found so far. We've collected a lot of additional information that we haven't even put into databases yet, and looking at some of the early data related to barriers, we asked folks or directors who said they weren't offering these programs what the barriers were, and not surprisingly, a lot of the financial barriers rose as the highest rated barriers, and some of the barriers related to treatment philosophy weren't rated as high, but those results are really preliminary at this point. So where do we go from there? It's sort of clear that there's a possibility that naloxone education and prevention programs could be offered across all of these different types of programs. And given the potentially high levels of education and distribution programs in halfway houses and CBCFs, are these ops necessary, feasible, prioritized, and for those programs that are already providing these types of operations, are they effective, and can they be improved in their effectiveness? It gets to study two. We applied for some money to answer those research questions, and the title of the study is Quasi-Experimental Comparison of Opioid Overdose Prevention Programs Delivered in Southern Ohio Correctional Facilities. It's the same funder. It's a relatively small amount of money for both of these projects. So going back, we look at the literature. So what do we know based on the literature? And there's really clear evidence from meta-analyses of ex-prisoners, studies including prisoners and ex-prisoners, that they have some of the highest rates of drug overdose death globally. And more than that, there's a pretty narrow window where most of these overdose deaths are occurring. And they're 2 to 4 weeks after prison release in individuals with a history of substance abuse disorder. And that's 2 to 4 weeks, significantly higher or more likely than 4 to 12 weeks. There's been a pretty good set of studies that isolated this window of opportunity for prevention intervention. When we look at gaps in the literature, when substance abuse treatment facilities or substance abuse programs in correctional facilities are studied, their outcomes are typically recidivism. That's the focus of these studies. They don't include mortality or survival outcomes. And then there's a general sense that studies haven't investigated correctional facilities as distinct elements or units of analysis in the cascade of care for opioid substance abuse disorder. And for those of you that have some knowledge of sort of the language related to HIV/AIDS prevention, getting to a cascade of care is sort of an achievement in a treatment model, I think. And That sort of sense of treating people in a cascade of care isn't really applied for people with opioid substance abuse disorder, in my opinion. So we use sort of a textbook approach. If any of you have taken a health education course here, or you've assigned health education readings here, you may have assigned something about the Precede-Proceed model. This textbook's been around for years for NPH programs, and basically suggests there's a series of assessments, really needs assessment, that anybody should take if they're planning a prevention intervention. There's a set of assessments that you do before you implement that program, and then proceeding and through the program, there's additional sort of set of steps that they support. When we did our own needs assessment, looking at the literature and what when Stanley and colleagues were doing here at the University of Cincinnati and what other really specialized teams are doing in other places, you find that the literature supports a pretty clear set of risk factors for opioid overdose death, and they are abstinence, meaning release from incarceration or a treatment program in that period when people have really low tolerance for the drug that they used to use on a regular basis. So you use a certain amount of heroin for a long time, you go through detox, whether it's willing or unwilling, you effectively go through detox and then come out, and your body isn't accustomed to using that same dose anymore. So that's how we're defining abstinence. Also, dose and changes in purity, especially adulteration with fentanyl, as we're finding, addiction history, previous overdose, chronic medical illness, polypharmacy, and social isolation, which just really concrete example of that is using in a public bathroom. These are all really well-established empirical risk factors for death, overdose death. When we look at the prison literature, there isn't quite as much quality, I would say, public health research out there, but there's some, and a lot of that research is sort of summarized in these three citations down there below, and they indicate that injection drug use, which people oftentimes pick up as a sort of behavior while in prison, and other sorts of unsafe drug administration practices that people are exposed to in prison and continue to do afterwards. That's an important risk factor for premature mortality. Access to basic needs. Some people get into prison and obviously they didn't have housing before, they didn't have medicine before, they didn't have a lot of other things, and they get that in that sense that it's health protective. And then when they leave, there's this period where it's questionable whether you're going to lose all those benefits or you're going to sustain them in some way. So that sort of question of linkage to care is a significant risk factor in premature mortality for prisoners. And then legal status, which is a more complex risk factor. But as we're defining it and looking at it for the intervention, it's really understanding your legal status and having some knowledge of how your legal status may or may not relate to the existing Good Samaritan provisions of the law. What's going to happen if you call 911 and you're a convicted felon and the police arrive? That's how we're kind of investigating legal status. I'm not going to get into these, but these are just a small list of some of the legal status variables that people within our facilities are subject to, sort of non-federal versus federal clients. That's a simple one, and then the others are a bit more complex. And we can talk about that at the end if people care to ask about that. So we're still sort of in the pre-seed needs assessment phase, looking for kind of local research. The EPI-8 investigation was really useful, but basically it didn't produce any kind of new recommendations or new risk factors that weren't already present in the literature. It reinforced some of the demographics that are associated with overdose risk, and it also reinforced the fact that recent release from any institution within the last month was associated with risk of death. And again, their study focused on risk of death from fentanyl versus other drugs. But still, these as a sort of proper needs assessment as a component of the pre-seed model. Local investigation of local epidemiology is important. So even though the research center, as I said, we've been around for a couple of years, and we're within Talbert House as the broader agency, we still kind of see ourselves as independent investigators. So we consider Talbert House a partner agency in this sense. So they're allowing us to partner with them and talk to some of their clinical supervisors, their directors, specifically within this court and corrections bubble, which is just one part of the service profile of Talbert House. So they're allowing us to work with them and develop this peer ops intervention. And just having the knowledge and access to the policies for the broader agency, which includes outpatient behavioral health for adults, youth behavioral health services, these community care programs, and housing services, that's really helped us learn a lot more about linkages to care and really is, I think, helping us develop tailored intervention that could be used across a more generalizable set of organizations and not just Talbert House. So, for instance, they're linking us to the syringe exchange program, Cincinnati exchange program. We have some sort of affiliation with them through the organization. So we think about how our organization affiliates with syringe exchange programs, and as well as how other organizations throughout the state might do that. And then there's Project Dawn, which is a health department-driven effort to get naloxone out there. So we've considered ways to refer people to those organizations as well. And those are available throughout the state. So there's sort of the Talbert House model and linking that to syringe exchange programs, Talbert House model and linking that to health department efforts. That's how we're kind of thinking about the model at this point. So getting back to where we started, post-entry, exit, and recovery ops in 3 phases. This is a product of looking kind of closely at the mission of Talbert House, aligning that with what SAMHSA defines recovery as. And at this point, we're really searching for a range of different curricula, video content, kind of whatever we think we may be able to pull together that can affect some of the risk factors that we're sort of reprioritizing and deciding to focus on. We're at kind of a funny development stage where at this point we have some preliminary risk factors, but these may change through focus groups and other sorts of investigation with clinical directors going across the different sites to talk to not only the people running the different sites, but the people that are living there. But anyway, this is sort of the preliminary targeted risk factors for peer ops. We sort of elevated social isolation to the top because it's built into the model of Talbert House proper, and really any halfway house, community-based correctional facility, any sort of recovery agency is focused on something called social reintegration. And so it makes sense to sort of focus on social isolation as a construct within these settings. Others are listed here include dose and changes in purity. For Ohio, fentanyl knowledge is obviously really important. Legal status, access to basic needs, and then the general notion of self-efficacy and skills for naloxone administration. And my background focusing on HIV/AIDS prevention, that's sort of a well-established construct that's effective for behavioral interventions. So I'm not sure if you all are familiar with the concept self-efficacy. It's sort of just common term in my field. This is one of the ways that we're pulling curricula together. We're just sort of scouring the internet. Some of the interns that have come through and other folks I've asked to just go on YouTube and find all the videos that exist. We've looked at, obviously, other types of places for these videos, and we're sort of organizing them into a matrix to identify really theoretical elements, just how much time the video is, and we may be cutting some of those pieces of video together and presenting that in focus groups and other sorts of settings to get people's sense of how relatable some of the content is and how useful it may be. So as you can see, there's local news organizations put out stories on fentanyl, as I'm sure you've seen. National news organizations, places like Harm Reduction Coalition, all these places that I've been mentioning put out some sort of educational video components at this point. So it's really a paper that somebody could write, how to survey the internet for those sorts of videos. We have to organize some of those activities, that content, into modules and align those with health determinants and outcomes. We have focused on some immediate outcomes, intermediate outcomes, and distal outcomes. For the most part, all the risk factors that we're targeting are empirically linked to survival. So the distal outcomes are all reduced overdose mortality. Intermediate outcomes include other constructs, including increased naloxone use, knowledge of fentanyl. Immediate outcomes, self-efficacy, and decreased addiction stigma. Some of one of the reasons that we sort of settled on peer ops in the short term is the prioritization of social isolation as one of the constructs, and getting staff and clients to talk to one another, staff to talk to other staff, clients to talk to other clients about treatment and prevention and how to access their social networks of folks who may be at risk once they're discharged from the facility. That's a construct that we're thinking a lot about and talking to folk about, but we're, as I said, still in the development stage, and we may still reprioritize some of the target areas. These are the data that proper power analysis would be based on when we're thinking about doing power to understand how many subjects we should include in this type of longitudinal study. You can see here, these are just pulled from our own records, a sample of, or Talbert House records, a sample of 10 facilities. For study 2, we're actually looking at 11, but this is just data on 10 facilities. They serve men and women. They serve on average, they serve the age range that's highest risk for overdose death. They're mostly white in terms of race. That's a risk factor in this area. Mean education, they typically have high school education or less, or on average grade 11. You can see opioid substance use disorder, and these aren't director reported. These are DSM qualified opioid use disorder diagnoses across our 10 facilities. I think the lowest looks like about 30%, 21%, 30%, up to 70% of clients in these facilities have a diagnosed substance use disorder. So there's a range of length of stay across our different facilities, but basically everybody in these facilities are coming out in a relatively short period of time, entering that really high-risk window for overdose death. And so regardless of sort of study funding, the agency is focusing a lot on ways to improve naloxone education and prevention interventions across facilities. And at this point, we're still building our study, and hopefully we'll be able to show something on odds of overdose death, comparing the peer ops innovations that we're working on versus the standard of care. Where am I with time? Still got a little bit. So these are the 3 major goals of Study 2, to test the enhanced ops intervention. So we're working on standardizing some pieces and working with clinical directors to maybe include a short video piece across all our facilities where that doesn't exist currently. There's some other aspects that we're working on that we believe should be administered across all our facilities. Getting back to whether peer ops should be a standardized form, all these facilities, I should have mentioned earlier, have their own tailored set of intervention services. So thinking about bringing in a brand new lengthy 3-4 hour intervention on this topic is one way to think about it. But another way to think about it is these clients are all residential clients. They're all exposed to some form of services already, And a lot of the service providers there feel like they're already doing a really good job. They're incorporating some of these pieces in their programming as it exists. So that's just to say we're still developing exactly what the length of the peer ops intervention is going to be and exactly how it's going to be fit across all these facilities. But you can see some of the references below. Bennett has tested changes in knowledge on these factors, so we're using some of their measures and using their effect sizes to determine post hoc whether our studies should find statistical significance. The middle point I've talked probably sufficiently about. There's a goal is to assess acceptability and feasibility of the enhanced and standard ops. So we're doing a range of focus groups to kind of get at that. And then long term, to look at the mortality outcomes, we're linking to the National Death Index to get mortality 12 months out. Intermediate outcomes include self-rated health status and use of naloxone. If any of you have looked at self-rated health status, it's actually a really good predictor of overdose death, or excuse me, death in general, sort of accounting for all the other risk factors, cardiovascular health, lots of other things. There's 20 years of research that shows that you can account for all the risk factors in two different groups, and still, if you ask them the self-rated health status, it's going to explain some statistically significant portion of risk. So we're sort of excited about the possibility of looking at self-rated health status as a mediator in that mortality model, and then possibly applying self-rated health status in a little bit more clinical way to link people to a higher level or lower level of services or more targeted intensive services. But that's a research question. It's sort of a personal research question, not an agency research question. I think that's about it. This is what that model looks like that we're planning. You can see there's an 18-month time frame. We're going to start collecting data really as soon as possible. We're in UC's IRB right now to get approval for this study. And then we'll be collecting, it's non-randomized, it's across all our facilities, so we'll be collecting data for all new intakes, pre-post data over a 3-month period. So we'll miss some people, but that's the time frame we're planning for. And then 5 months out is when we expect to incorporate the standardized peer op intervention. And we'll compare the earlier cohort to the cohorts that come through later who receive the enhanced intervention, and then look at, down the line, what mortality looks like. So a handful of limitations for each of the studies that we should talk about. Low response rate. I mentioned, I think, there's no compensation for people's time, so that's a big problem, presumably contributing to that low response rate. The sample that I was hopeful that we would get when I started at the center about a year ago is clearly not panning out, so we're not going to be able to do some of the more sophisticated multi-level modeling, at least with the director data. We may be able to do some more sophisticated modeling of the staff survey data because we have about 680 staff surveys that were returned, and that's a random sample of staff across the 141 facilities. So that'll be an interesting sample to look at. And there's been some laws that have changed since the inception of the study design. So some of our ways of asking about naloxone distribution could have been a little bit better if we knew in advance that the law was going to change. Strength, I guess, we're including facilities that aren't captured in NSATs or anywhere else to our knowledge. We're achieving a sample size in Ohio that's comparable to a Harm Reduction Coalition, which is a national sample. So on that level, it's a relatively good study. Study 2, again, we don't have a compensation for participants. That's usually something that's budgeted with an NIH or CDC or other type of well-funded study. We don't have a budget line for compensating participants. There's also issues related to prisoner research that are a bit more difficult if you haven't conducted prisoner research. Sampling is limited to Talbert House. As I said, we're sort of developing an intervention model that we hope is a bit more generalizable, but the data are still going to be just based on Talbert House clients. We haven't gotten a HIPAA waiver, which just means that in some mortality studies, you actually don't need to consent folk. You can get their records from agencies like Talbert House. You get their Social Security numbers, and you can link that to publicly available recidivism and mortality data. But you need to go through an IRB and get a HIPAA waiver to do that type of research. So our sample is going to be limited to folk who have consented to, you can use my Social Security number and link it to my death record. So we'll see how people respond to that piece of the consent process. A major strength, as I hope I've illustrated pretty well, is we're accessing a really high-risk population during periods of amplified risk and personal susceptibility, and we're going to study how just general standard of care compared to some small improvements and advancements in intervention, how they align with mortality and community integration and reintegration in general. So at 3 months out, I guess I skipped that as a piece. We're going to ask some questions about where people are at, what they're doing. So that'll be another piece that hasn't been published in other research. People generally don't follow prisoners beyond the high-risk period and try to follow up with them. So we'll be calling people who are 30 days out of our programs just after that really high-risk window of opportunity for death, and we'll be collecting some data at that point on community reintegration and behavior. So that's it. There's a lot of people who have been helping with this study. I just want to highlight Tiffany Thomas and Tom Bach are some of the people at Talbert House, actually, that have been really helpful, helping us look at specific policy language and explaining to us how naloxone is distributed through our facilities in theory and in practice. Tiffany's been great. She's let me sit in on some of the groups that she leads that do training on naloxone distribution. This is something that I feel like everybody knows, so it's hard for me to describe it really well, but naloxone trainings really are just comparable to CPR trainings. I mean, in that sense, it's the same. It should be integrated into agencies, in my opinion, in really the same way. A lot of you are trained on CPR, and you have no idea why. It's just part of your job. You go get trained on CPR. The odds that you're going to use CPR are very, very low, that you're going to encounter somebody and need to use CPR. The reality is the likelihood that you're going to encounter somebody that needs naloxone are much, much higher. But when you get jobs in the next few years, if you haven't already had corporate jobs, you'll recognize that you'll get a CPR training in those places, but you probably won't get an naloxone training unless research and practice aligns a little bit more. So thanks. That's about it. I'll take any questions that people have.